Welcome back, everyone, to Open Line. We're talking about the opioid crisis. Where do we stand right now in Tennessee, and what is being done specifically through the courts? We have with us Debbie Tate. She's the director of the courts for the state of Tennessee, and Dr. Stephen Patrick, associate professor of pediatrics health policy at Vanderbilt. Doctor at Vanderbilt, thank you again for being here. Let's go to the phones. Let's go to Michael. Hello, Michael.
Yes.
Go right ahead. What's on your mind?
Sir, my mother passed away in 2005. I've been somewhat a caretaker for my father since that date, and he's had medical issues of a broken neck, broken back. He's had major surgeries, and I've been taking care of him, taking care of his medication, making sure his medication's handed out properly. At one time, he was even given a prescription of oxycodone. He took one, he went into hallucinations, and he said, "Michael, what is this that they gave me?" I said, "Daddy, please don't take this medication ever again." He went back and he got like a 10 milligram pain pill, and he was okay. He would take this before he went to bed at night so he could sleep well. But now he's getting prescribed all kinds of vitamins. He's getting prescribed all kinds of this and that, but he is hurting profusely. And I'm wondering why the doctors are not giving the people that really are in pain medication so that they could sleep well and live prosperously.
Okay.
It's like the doctors are scared to prescribe.
You think they've kind of made it harder to get some of these things? That it's hurting people who actually need them?
No, I believe that they have actually cut everybody off because they're scared to write the prescription.
All right, well, let's talk about that. Doctor, what are we seeing?
I think it does happen. I think we saw, Tennessee at one point had the second highest rate of opioid prescribing in the nation. And so nationally in Tennessee, everywhere we've had this massive response to opioid prescribing. And in some ways it doesn't always make complete sense. Tapering someone who's 80 off their opioid they've been on for 20 years doesn't really make a lot of sense. So I think we have pockets still of overuse, and we have pockets of underuse. And we have to work in a way where we take care of treated pain, particularly for people who are in chronic pain. It's more complex. And so we need to attend to that. But then be mindful of the way we do new prescriptions. So I think about this, and it's true in terms of policy, the way we write policy. It's really three different populations. It's acute pain, so when you get your wisdom teeth out, we shouldn't be giving you 400 oxycodone for that. Chronic pain is different, and then opioid use disorder. And we need to approach them differently, and it requires some nuance.
I am furious when we do this show and I hear from people who had knee surgery and then all of a sudden their lives are destroyed by this addiction.
Right.
And we hear that over and over, and it's almost, you feel like at times there were doctors who were like drug dealers pushing this stuff on people, and it's infuriating. I'm almost happy to hear if they're pulling back. Now there's some people who need it, I know, but you're saying we are pulling back. Yeah, doctors are not prescribing the way they were.
Right. Well, we've seen decreases, but what we need is a scalpel, not a hatchet. So we need to figure out a way to make sure that we're doing this in the right way. And we have seen some changes over the last 6 months to a year even. So the CDC released prescribing guidelines. They've been clarified a bit by the CDC as well as the Surgeon General, who is an anesthesiologist, to talk about how we're implementing them. Does it make sense? Because there are cases where people getting tapered off their opioids and then committing suicide. So we really have to have some nuanced conversations about this with patients, particularly patients in chronic pain. It is not a one-size-fits-all approach.
There was a time, and then we'll move on, but there was a time where there was one prescription for every Tennessean, or something like maybe two prescriptions for every Tennessean.
Every man, woman, and child in Tennessee.
Yeah.
And now it's down, right? So I see a statistic now, 1,000 Tennesseans get 901 prescriptions. Yeah. So that's down.
Yeah.
But I guess you think it should be tightened, or where do you think we should be? I like the idea of a scalpel and all the things you just said, but
it needs to be less than it is.
Yeah.
Period. But it needs to be done in the right way. I mean, if you look at use overall, most use is overprescribing of these acute cases. Right, that's what we need to, and thinking about it moving forward for that knee pain, that shoulder surgery, or whatever. And we're learning more and more, even about, we do a lot of work around childbirth and delivery. The amount of opioids we prescribe after a C-section, for example, some of our colleagues are working on. There's extra left over. And we know that for some people, they chronically use opioids after a C-section. So we need to have these conversations with folks about it and the way we counsel, because there is a right use to this. We don't want people in pain, right? That's why they're there to begin with. They have a use. But we need to be mindful of the way we do it.
So we're talking about resources now. What are the new resources? Fascinated, the courts are really getting involved, judges are getting involved. So what are some of the new resources that the courts are going to be focused on?
Sure. So we really recognize that, judges don't go to med school. Judges didn't even know what the medical terms were, and certainly not all these drugs, and there are new drugs that are released, all of the time that have been approved for use. And so one of the things that we did, and I know that Channel 5 will be putting all of these, a link to all of these resources, but we actually created an entire resource center for courts, and it was everything from prenatal substance exposure, which the doctor's been talking about, treating pregnant women, medication-assisted treatment for adolescents. At every age along the way, we tried to give judges real tools and real information. It's funny that you spoke about the Surgeon General, because we are going to unveil all of these at the National Press Club in Washington, and our guest speaker is the Surgeon General. His office previewed and reviewed a lot of these, SAMHSA, HHS, and so we feel very good about the resources. And what's great about them, Ben, is they're not just for judges. This could be a Kiwanis club. This could be your church. I mean, that people could actually go in and just print these off for free. So again, all of these are going to be available. We're probably up to about 50. One of the ones is strategies in rural areas, because we know that there are lots of rural areas that don't have access to certain services. One of the other things that I wanted to be sure that we leave is these red cards with the Tennessee Red Line that anyone can call for private consultations. And I brought a little red phone that I'm going to leave on your desk. And then, of course, for free legal help, there is help for TN. And so I brought bracelets that I will leave as well. So people can call and get free legal advice if they need that, or a free consultation if they feel like they need services anywhere in Tennessee.
And there's some other stuff we'll get to, but okay, that's great. Let's go to Philip, I believe. Is it right? Philip? Phyllis.
Yes.
So sorry, Phyllis.
Hi,
go right ahead.
Thank you for the call. Can you hear me?
Yes, ma'am. Go right ahead. Thanks.
Oh, good, because my phone breaks up. I live quite a ways away from, the doctor appointment and pharmacy, but I have taken the same dosage of painkillers for 3 years now, and I would hate for people to think that everybody abuses their prescription, and for people that are responsible and they take their prescription for painkillers, they shouldn't be put in the same category as opioid abuse. And I would never even dream of taking heroin or anything like that. And I wish that they would please do not categorize people that take responsibility for their pain meds with this opioid crisis.
Okay. All right. Thank you.
All right. Thank you.
We get calls like that a lot whenever we do this show from people who are using them.
Right.
They say responsibly, and they're worried about any sort of effort to change things. When it's obvious we need to change things because it's a disaster that's unfolding. And so Phyllis sounds, I'm sure she's reasonable, but how do you allay the concerns of people that are using these things and at the same time deal with the crisis that is in front of us?
Well, one of the things is Phyllis probably hasn't been brought into court or shackled or, any of the ways that the court system becomes involved with these people. Hopefully she didn't use and bring a baby with NAS into the world so that, Vanderbilt and neonatologists would have seen that. And so some people are using the drugs that they are prescribed. I remember that my mother-in-law had a pain patch, for end-of-life pain, because you're exactly right. The doctor is so right. There are different types of people. People react to drugs in different ways, and then just the particular condition or age that they are has so much to do with this. So it is truly that we do need a very tiny scalpel.
So the challenge is that these medications, even when used as directed, can lead to opioid use disorder. They can lead to, and that's really the challenge. And it really is what you're talking about, Ben, like the complexity of this. The beginning part of this crisis was overprescribing of prescription opioids. It was a lot of bad actors, including a large pharmaceutical company so we do have to do things differently than we're doing. And it has to be mindful of people like Phyllis and others, but we have to do something different than we're doing. We have to hear Phyllis, we have to create policies that are mindful of Phyllis, but we still are overall as a population using way too many prescription opioids. So how can we create policies? And we see states changing their laws a little bit in terms of like the way we prescribe for a sprained ankle is different than we do for somebody in chronic pain. But we do have to do things differently than we are now.
And there's no doubt about that. We have to change. There is no doubt. There's a map, right? The opioid misuse tool. You were talking about these tools.
Yes.
There's another tool. And this, I thought it was interesting. You're talking about you go to your church and talk.
Yes.
And I bet when you do, it opens up an opportunity for people to kind of talk back and begin this dialogue.
Absolutely.
But what is the opioid misuse tool? And we're going to try and show it. Look at that. Oh, we did it. All right. What is this?
Well, and so when you look at the darkest colors that you see and where they are, and you can actually zero in to your own particular county. So, if you choose a county in Tennessee, especially in the darker areas, you're going to be able to to see a lot of information. I know that Dr. Patrick has done a lot regarding the economics of a particular area and the impact or how it correlates with the opioid crisis. And so, these are maps that the federal government is starting to put together. Another one that I'm very interested, and I didn't find it in time for today, but it is all of the federal funding that is available for states to utilize in this opioid crisis. And what's amazing is that the resources that have been unleashed, the Department of Transportation, the Department of Energy, people that we would have never thought to come together in a health crisis are now realizing that it is going to take all of us at the table. And so I want to make sure that when that is available that you all have that as well.
What kind of stands out when you look at that map for Tennessee?
So eastern part of Tennessee, and if we put a map from Tennessee Department of Health reporting on newborns with opioid withdrawal, it looks like that. If we look at cases of hepatitis C virus that are broken out, it looks just like that. And it is disproportionately eastern Tennessee. But what we've seen so if we go back, if we were to look at that map over time, it would start in the eastern part of the state and it spreads across the entire state, like you would see a virus spread. I want to come back to overdose deaths because there are things we know that people can overdose on prescription opioids. That's what led to some of the crisis. Using other medications like benzodiazepines, these are drugs like Valium, can enhance that risk. Also alcohol. So those are things that are important. It's worth talking to your doctor. And CDC guidelines have things like have naloxone if you have certain doses of an opioid. And so naloxone is an overdose reversal tool, and it's pretty darn easy to use. So this is an example of one of them. So this is just a trainer. This is really all you do. So the medicine is in here. You put your thumb on it in the nose, and you just do that. And it's like if you are not having an overdose, it's like water. I could give naloxone to any one of us here and it wouldn't affect us.
Wow.
But it's incredibly effective at saving a life. If you overdose on an opioid, it suppresses your respiratory drive. You stop breathing and that's how you die. The naloxone immediately reverses that and it gives you time to call 911 to get help. So naloxone you can get at CVS you can just go and get one. It's expensive. We were talking about this before.
Yes.
About $100 if you do that. With insurance will cover this as well. But Surgeon General suggests that everyone carry this. Certainly if you have opioids in your house, it's a good thing to have. It will save lives. And it's why we think we've started to see nationally a little bit of a decrease in deaths but naloxone is not enough. We need more treatment, including medications for opioid use disorder.
We get reports from the fire department about how often they're using that.
Yes.
And sometimes two, to bring somebody back.
And it's pretty astounding how often the fire department's having to use that. And it is expensive, but it's I didn't know that's how it worked. That's very interesting.
You can give it different ways. So if I'm in the hospital, I usually give it IV, right? But it works intranasally. And so if we're talking to the public, right? So people are less likely to go give someone an injection, far more likely to give somebody an intranasal spray.
So my church now has it. You know, I feel like everywhere I speak, people go out and buy it because you never know. The courts, you know, we have people who overdose sitting in a courtroom. As you mentioned, the fire department, I know one of the first meetings I had was with the mayor. His concern was one of the budget items was every single fire truck needed to have multiple doses of Narcan on it because they are our EMTs. So all the police officers need it.
Amazing. All right, I'm going to take a break. If you want to call in, there's the number, 615-737-PLUS. What do you think about what we're talking about up here, the opioid crisis, where we stand, what's being done? There's the number, 615-737-PLUS. Take a break, be back right after this.